we are going to discuss about cord prolapse. Cord prolapse, it is the abnormal design of the umbilical cord. Details about umbilical cord. Umbilical cord is a connection between the fetus and the placenta, which provides the nutrients and oxygen to the baby from maternal circulation. So, as I said, the cord prolapse, it is an abnormal design of the umbilical cord, and there are three types, that is open prolapse, cord presentation, and cord prolapse. And these three entities, clinical entities, these three are placed under the same heading, that is cord prolapse. There are some differentiation between these three, but collectively these are placed under the heading, that is cord prolapse. And this abnormal descent of the umbilical cord, umbilical cord is descending abnormally, and that too by the side of the presenting part, that is known as cord prolapse. Next, we will see in detail about each of them. The first is occult prolapse. Occult prolapse, it is the cord is placed by the side of the presenting part, and it is not felt by the fingers on internal examination. Here in this case, the umbilical cord is placed by the side of the presenting part, and we cannot feel the umbilical cord by the fingers during internal examination. Right? So the umbilical cord is lying on the side of the presenting cord, whichever the presentation is, whether it is bridge presentation or it is a phallic presentation or lower face, irrespective of the presentation, the umbilical cord is situated by the side of the presenting part, that is known as occult prolapse. Next is cord presentation. In this case, the cord is slipped down below the presenting part. So cord is descent, it has been descent, but it is situated, it has slipped down below the presenting part, and we can feel it is felt lying in the intact back of membrane. Here you can see the presenting part, and the cord is lying below the presenting part, and the back of membrane, that is the membranes are intact, it has not ruptured. In the next case, that is in cord prolapse, the cord is lying inside the vagina or outside the vulva following the rupture of the membranes. Here you can see the cord is by the side of the presenting part, and it is lying below the presenting part, and even it is inside the vagina, or even we can see it outside the vulva. And here the membranes has been ruptured, so we can see the umbilical cord through inside the vagina, as in some cases even it can be seen outside the vulva. So that is cord prolapse. So next we will see the incident rate of incident, that is among 200 pregnancy, one case can be of cord prolapse. Nowadays, the incidence is reduced due to the use of cesarean section in non-cephalic presentation. Nowadays, in non-cephalic presentations, that is other than the cephalic presentation, nowadays everyone is opting for cesarean section. So the incident has been reduced. The causes are malpresentations, contracted pelvis, prematurity, twins, hydramnios, placental factors, that is minor degree placenta previa, long cord. Then iatrogenic, that is when the low rupture of membrane happens, and even when the manual rotation of the head has been done. Manual rotation of the head is done, and in external cephalic version and internal podalic version. Version is we are changing the lie of the fetus. Okay, so if the baby is in oblique lie, then in order to do the normal vaginal delivery, we are performing the version, we are making the lie in a favorable manner. So that is version, it can be external or internal. Next is stabilizing induction, that is we are doing the induction of labor for accelerating the labor, for conducting the normal vaginal delivery, that is using osteostrip and rupture of membrane. So these are the causes for the cord prolapse or cord presentation. Next is diagnosis. So we know there are three: occult prolapse, cord presentation, and cord prolapse. In occult prolapse, that actually it is difficult to diagnose, and we can suspect this case when While monitoring the fetal heart rate frequently, continuously, the fetal heart rate is decelerating. It is reduced continuously. Then we can suspect this case as occult prolapse. The another one is cord presentation. In cord presentation, what happens, as we said in the definition, that the membranes will be intact. So we can feel the cord pulsation through the intact membrane. That is the difference. Cord presentation, feeling the cord pulsation through the intact membranes. Next is cord prolapse. Here, cord is palpated directly by the fingers. Directly we can feel because the membranes is ruptured. And then pulsation can be felt if the baby is alive. Okay. And whenever the whenever contractions are present, the pulsation will stop, and as soon as the contraction stops, the pulsation will again return back. So that happens in cord prolapse. Here directly we can feel the umbilical cord because the membrane is structured, and even in some cases it can be seen outside the vulva. No need to do any internal examination. At the vulva itself, we can see the cord has been prolapsed. Okay. So next, we'll see the prognosis. You know what happens during this cord presentation of prolapse. What happens? The umbilical cord is being compressed by the presenting part and the pelvis. So what happens due to the compression of the umbilical cord, the baby will not be getting sufficient amount of oxygen and other nutrients, whatever is needed for the baby. So what happens? The baby can go to anoxia and even the death can happen. But if the condition is detected soon and the treatment is given as soon as possible, then this we can reduce the mortality rate. So the most important thing is that we should be keen enough to identify this condition, and we should be skilled enough to provide care for this type of patient. Okay, so by providing the care at the correct time, we can reduce the fetal mortality rate up to 5 to 10%. Then in maternal risk, as it is an emergency condition, and in this emergency condition, the mother may be um, may in some cases the mother we will take the mother for cesarean section or any other operative delivery. So there can be the risk due to operative delivery. So that is about the prognosis. Next is anticipation and early detection. So as I said, we have to early detect this condition. Then we can provide the care and the life can be saved. So here, whenever we do the internal exam, whenever a patient comes with PV leaking, genuine leaking, or premature rupture of membrane, so immediately what we are supposed to do the internal examination so as to exclude this condition. Okay, and if we are performing surgical induction, we are supposed to conduct it in the operation theater, and oxytocin infusion should be started before the long rupture of membrane. And whenever we are performing amniotomy, that is artificial rupture of membrane, if we are performing that, so before and after this procedure, we should do the internal examination to exclude this condition. Whenever we do the amniotomy, before as well as after, we should do the pervaginal examination to see, to feel whether the cord has been prolapsed or not. So that is about the anticipation and early detection. So next we are moving on to the next. That's in general the management. The first thing is we should call for the help, then we should organize the delivery, then the most important thing is we should relieve the pressure on the cord and deliver. Okay, so it is a mnemonics, that is CORD. It's called for, we should call for the help, we should arrange for the delivery, and the most important thing is that we know in cord presentation or cord prolapse, whenever the uterus contracts, when the baby is descending, the cord is being compressed. So in order to remove that compression, in order to relieve, we should implement some measures. Okay, then deliver, and then we have to deliver the baby. Okay, so one more thing, whenever in the case of cord prolapse, uh, we will be opting for a vaginal delivery, or in most of the cases we will be opting for the cesarean section. So during the preparation of the mother to the operation, for the operation, during that time the patient should be the cord has been prolapsed. It can be seen outside the vulva. So what we have to do, we have to cover this umbilical cord sterile, saline goes. Because if the umbilical cord it exposure to air, it gets irritated and it can cause vasospasm. It again it worsens the condition of the baby. So in order to avoid that, a sterile saline gauze has to be uh, uh, the cord should be covered with sterile saline gauze. Okay, and even we can reduce infection also in this case. Next is the management for the cord presentation. So once the diagnosis is made, we should not try to replace the cord back. Okay, and if immediate vaginal delivery is not possible, or it is contraindicated, vaginal delivery is not possible, or the baby is having malpresentation, or the it is abnormal line. In these cases, we cannot do vaginal delivery. So the best treatment of choice is cesarean section. And while preparing the patient should be kept in exaggerated sun position to minimize the cord compression. And in some cases, it is very rare cases, the mother may be multipara, the lie is longitudinal, there is good uterine contraction is there, and cervical dilatation has reached up to 7 to 8 centimeter, and the baby's condition is good. FHR, fetal heart rate is also good. In this case, everything is positive, and even the cervical dilatation has reached 8 centimeters. So the mother is in first stage. So only few hours is remaining to reach to complete the first stage of labor. So what we can do in this case, we can uh, expect for, we can do actual. So we can perform watchful expectancy can be adopted till the full dilatation of the cervix, and in the second stage of labor, we can shorten the duration by we can do the forceps or breech extraction. Okay, so that is a management in case of cord presentation. Next is the scheme of management for the cord prolapse. So, if it is a cord prolapse case, we have to assess whether the baby is alive or dead. We have to see the maturity of the baby, and we have to see for the cervical dilatation. Okay, and in case if the baby is dead, we have to confirm the death by sonography, because in case in cord prolapse, there are chances of um, deceleration of fetal heart rate, and even we cannot feel the pulsation. So by that we cannot confirm the death of the baby. We should confirm it with the ultrasonography, and we should wait for a spontaneous delivery, vaginal delivery, or otherwise, if it is not possible, destructive operation like phlebotomy, decapitation, or ulceration can be done. And if the baby is alive, the best treatment of choice is cesarean delivery, and if the vaginal delivery is not possible, immediately if it is not possible, by that time we can do the first aid management like bladder filling, then exaggerated sense position, knee chest position, or frontal bulb position can be done, and even we can lift the presenting part of the cord. These 3 points will be dealing in the next slides for the explanation, and then definite management is the cesarean section. But if the immediately if the vaginal delivery is possible, if it is cephalic presentation vertex, then we can do the forceps or windows, and if it is breech extraction can be done. Okay, so that's about the scheme of managing the cord prolapse. So we will go in detail about the first aid measures. That first one, that is, as we said, we can lift the presenting part. You know, here in this case, in this picture, it's a cardiac presentation. So we are lifting the head above so that the compression over the umbilical cord can be reduced. And next is knee chest position can be given so that here the woman's thigh should be at right angle to the bed and her chest flat on the bed. And another one is the woman's hip are elevated with two pillows. This is often, in many cases, we can combine this position with the frontal bulb position. So this can be these three measures are done in order to relieve the pressure over the umbilical cord. So meanwhile, we will be preparing for the cesarean section or vaginal delivery. So that is about the first aid measures, and we will just see one thing we miss, that is bladder filling. So Bladder filling, this is also done with the same motif that it will raise the presenting part of the compressed cord till the delivery. Here the urinary bladder is filled with 400 to 750 ml using the Foley's catheter. We will be instilling 400 or 400 to 750 ml of normal saline. And when the balloon is inflated, we will be clamping the catheter. So that is, the bladder will be filled and the compression over the umbilical cord can be reduced. So that is about the bladder filling. So that is regarding cord prolapse. It contains occult prolapse, cord presentation, and cord prolapse. So that is about this is about this topic. So we should understand what is occult prolapse. It is here. The umbilical cord will be situated by the side of the presenting part, and it cannot be felt per vaginally or internal examination. In cord presentation, the umbilical cord has been slipped down the presenting part, but the membranes are intact. In the third one, that is in cord prolapse, here the umbilical cord is lying down the presenting part, even it reaches the vagina, even it can be seen outside the vulva. Here the membranes are ruptured. Okay, so in the management aspect for presentation, we have to treat the best treatment is cesarean section. Meanwhile, preparing for the cesarean section, the measures, pressure relieving measures has to be taken, like bladder filling, knee chest position, trundle bar position, or exaggerated sims position has to be done. Okay, so that is about this condition. So I hope you got some idea about the cultural labs, and you can refer DC Datta, JP, DC Datta, then PB textbook for obstetrics, and even you can refer the emergency card page. Okay, okay, thank you. Have a nice day.